Leighton, is it? I've got that. Apologies. Thank you for attending today. We've got a couple of apologies. That's from Warren and Sally Yeomans attending in his absence, and Louise Barry. And unfortunately, Paul Cummings has not been able to join us today because he's ill. I'm going to go around the table and ask the board members to introduce themselves. Anne, if I can start with you.
Thank you very much. My name's Anne Moore. I'm Chief Executive of St Helens and Merseyside Hospitals and Southport and Ormsirk Hospitals. I lead the Acute and Specialist Trust Provider Collaborative in Cheshire and Merseyside, and I'm here as a partner member.
Good morning, everyone. My name is Anthony Middleton. I'm the Director of Performance and Planning at the ICB.
Good morning, I'm Christy Douglas. I'm the Director of Nursing and Care.
Good morning, I'm Claire Watson. I'm the Assistant Chief Executive.
Good morning, I'm Neil Large. I'm a Non-Executive Director.
Good morning, my name's Claire Wilson. I'm the Finance Director.
Good morning, everybody. I'm Mark Palethorpe. I am the NHS Place Director for St Helens, and I'm also the Executive Director for People Services in the Council, which includes Children's, Adults and Public Health.
Graham Irwin, Chief Executive.
Raj Jain, Chair.
Hello, Erica Morris, Non-Exec Director.
Good morning, Rowan Pritchard-Jones, Medical Director.
Well, I'm Steve Brimmer, Chief Executive of Warrington Borough Council. I'm here to represent the interests of the three councils in Cheshire.
Good morning, Tony Foy, Non-Exec Director.
Good morning, Chris Samosa, I'm a People Officer.
Good morning, I'm Joe Rafferty. I'm Chief Executive of Merseyside Trust. I lead the Mental Health, Learning Disability and Community Services Collaborative, and I'm on the board as a partner member.
Hello, I'm Fiona Lemons. I'm Deputy Medical Director.
Sally Yeoman, Chief Officer at Halton and St Helens VCA, and here for Warren Escadale.
Thank you.
Good morning, Jane Parkinson Loftus. I'm the Manager of Health Watch St Helens, and I'm here to represent the 9 Health Watch across Cheshire and Mersey.
Good morning all, I'm Adam Irvin, I'm a community pharmacist, and I'm here as a partner board member for primary care.
Thank you. Okay, just to remind us that this is a meeting held in public. I am delighted that members of the public have posed some questions to the board, and we'll come to those questions at the end of the meeting. We won't be able to answer all the questions, unfortunately, but we will make sure all questions are answered. So, thank you. Are there any declarations of interest pertinent to the agenda? No. Can I turn to the minutes of the previous meeting and seek any corrections, comments or clarifications before asking you to approve them? No, so I can have your support in approving those minutes as being correct. Thank you. Return to the board action and decision logs. There are no actions that are pertinent to today's agenda. Are people any comments or questions on those two documents? Noting. Steve?
Just raise item 2205 around reservation and delegations. I know this is in the foothills of this organisation and it is early days, but just to raise the issue of delegation system procedures for the 9 places. We're going to a situation where decision making as a local place is being hampered by the fact there's a lack of clarity up to become delegations. And I raise this on behalf of the 3 places in Cheshire, but I think it's a system-wide issue for us, Raj, to deal with, just whether we can just speed up and get some clarity around those delegations moving forward. It's starting to hamper business as usual.
Thanks, Steve. Graham, do you want to give us a view?
I think the first thing that I would say is this year was always going to be a year of transition. The fact that the legislation was so late passing through Parliament, the fact that we were only established on the 1st of July, it was really important that we had stability. It was also really important to recognise that through COVID, the government had the NHS in effectively a completely different funding regime through COVID, and the government is now adjusting us back to a funding regime that is pre-COVID. When you come to the finance report later that Claire will be presenting, you will see very clearly the setting out of resources mapped across and mirrored onto two places, but we recognise that one of the things that is really important and is on our to-do list for this year is a really clear scheme of delegation with each of the places. I'm not going to commit today to which meeting it's going to come back to, but certainly, Steve, keep challenging us. It should come back, a really formal paper on that delegation later this year. But it shouldn't be something that you see here at the board first time. This should be something that we've worked on collectively together with our partners and made sure that we've fully engaged before we make a proposal.
Thank you. Happy to move on to the report of the Chair. One item from me. Last month we had the last of our previous iterations of the Health and Care Partnership Board. And from the 1st of July onwards, as I think we all know, is the time when we created our sister committee, which is the Integrated Care Partnership Board, which we are calling the Health and Care Board. And we've taken the opportunity at the last of the previous iterations of these boards. There's too many acronyms in this. I'm stopping myself from using them. Too many acronyms of that previous partnership board to take stock of the opportunities and the issues that arise in front of us, to refresh how the partnership board, which is the sister committee to this board and hugely influential for us all, how that's going to operate, what its purpose is going to be and how it's going to function. And working with partners right across the piece, across this next 8 weeks or so, we hope to be in the place of doing that refresh and recommending to partner boards what that new format, what that new purpose, what that new function and how we will operate into the future. The partnership board is one of the key engines for achieving our overall objectives. So we thought it was pertinent to take that opportunity, and partners across Cheshire and Merseyside will be involved in that, not just the statutory partners from local authorities and the NHS, but our wider partners from the voluntary sector and so on and so forth. A good meeting, but work in progress. Any questions or comments on that? I'm happy to move on. Move on to the Chief Executive report. Graham.
Thank you very much, Chair. I want to say a few general comments before I start. And that, first and foremost, is to recognise the ongoing and continued difficult operating environment, particularly for our frontline staff within the NHS. I, and I'm sure we all do, remain deeply proud and grateful to our frontline health and care colleagues. They continue to go above and beyond the call of duty as we manage significant pressures in the system. We are not just trying to do today's work today. There is all of the backlog from COVID that is still to be caught up with. Now, we maybe thought we were out of the woods in COVID, and depending on who you listen to and how you count the COVID variants, some people would say that during June and July we experienced the 7th wave of COVID going through our communities and through our hospitals. Not only have our hospitals, our GPs, our other healthcare professionals had to cope with that, but actually those who are at work have had to cope with a number of colleagues being absent and the significant challenge and burden and pressure that they put on that. So we remain proud. The NHS is a marvellous and a significant institution within our society, but we have to recognise that it is under pressure and it is under challenge, and that we have our meetings in the context of that. And everything that we can do to show support to our staff who work on the front line and actually build them up and support them is fundamentally important in everything we do. Now, turning specifically to the report that is in front of you, and I just want to reflect on the nature of a Chief Exec's report to the board.
I'm not going to introduce every item in here. I will rely on the fact that board members will ask questions and challenge as appropriate. And I'm going to kind of just talk generally about how I've come to put this report together for you. So the first thing is I've highlighted some issues in here that are very topical, have been in the local and the national news, and effectively they are here today just to acknowledge their existence and often signal what we're going to do about them and how we're going to bring them back. So a good example of that would be the GP survey. We couldn't have a meeting without actually acknowledging the significance of the GP survey, but we will come back in the autumn and we'll have a full report led by our medical director setting out very, very clearly the things that we are doing to support GPs in light of those survey findings, and particularly those around access. Another example will be things that are here because they're work in progress and they're a chance for board members to effectively have 2 bites at the cherry. I will bring things here to tell you that we have started a piece of work so that you have the opportunity to say, how do I find out more about that? How do I become involved? How do I put some checks and balances in through the process, rather than waiting for it to come back at the very end of the process with a recommendation? So 2 good examples of that in here. You will see through the finance report later the sheer volume of things that we are responsible for in terms of health and care in our area. But there are a few things that we're not responsible for, but that we will become responsible for by next April. And so there are 2 items in this report that talks about services that NHS England are still responsible for that they are going to delegate to us. Good example is one that you've heard on the patient story today. We are not currently responsible for NHS dentistry in Cheshire and Merseyside, but we will be by next April, and we actually know access to NHS dentistry is a real challenge. So we'll have something transferring to us that's going to be a big challenge from day one. But also, we're not currently responsible for all of the very high-end specialist services that take place in some of our institutions across the patch, and we are likely to become responsible for some, if not all of those, and a significant due diligence process to go through. And then the final thing I just wanted to draw attention to and highlight within here is I will sometimes bring things here for reasons of openness and transparency. Things that perhaps you've heard us discuss before, and we're quite clear that we will put things in the public domain through these board papers. So we were asked, could the public see the terms of reference that we have set for the Liverpool review? So again, contained in here is the full disclosure of the terms of reference that we have set for the Liverpool review. So as I said, Chair, I'm not going to talk to every item, and actually, if people do ask me questions on some items, there'll be some items in here which I'll be deferring to other colleagues around the table to answer for me.
Thanks, Graham. Any questions or comments? Thank you. Happy? Neil?
Could I just ask on the Liverpool review, because the objectives are extremely ambitious in terms of the clinical redesign in and out of hospital, and it refers to a revenue and capital perspective, giving recommendations on that. It's an ambitious programme in 3 months. I mean, who's been commissioned to do the work, and are they on target?
We've commissioned a firm called Carnell Farrer to do that work, and they held a kick-off meeting with the Liverpool system earlier this week, and they have set out very clearly to the Liverpool system their methodology, and they have set out very clearly a timeline. There is a little bit of contingency in that timeline, but also we're very clear about the constraints around how much money we're prepared to spend on such a review. So it's really important that
they deliver and that we hold them to account for that delivery as well.
Thank you.
Just a comment to say that it's quite reassuring that the responsibility for dental services is going to be transferred, because I don't think any of my Health Watch colleagues across Cheshire and Merseyside would disagree that there is a massive issue. It's something we talk to patients about every day, and again, it's just reassuring to know that that is something that will be dealt with at this level.
Thanks, Jane. Did you want to comment on that?
Well, the fact that we will take legal responsibility from the 1st of April next year, we shouldn't wait for that point in time. We should use the period from now until then to do some really substantial due diligence, understand all of the information that is available to us, not just what's been spent on these services, but as you heard on the video, the size of the waiting times, the waiting lists for access, what are the barriers to that access, and therefore be really clear that we hit the ground running with, shall we say, an improvement plan. But what I also know about dentistry, and it doesn't surprise me when you say this is one of the things that's at the top of your patient concern list, is there won't be any quick fixes. We will have to think about how we progressively improve this month on month, year on year.
Thanks, Graham. Joe?
Graham, on the same point about specialised services or NHS England, currently NHS England Health Services, the due diligence is a really good idea. The temptation might be to spend all of that time doing performance or financial due diligence. Are you proposing to do due diligence around a skills audit? Because this sometimes isn't about the money, but it's about the skills of people to do these really quite complicated commissioning jobs.
I think our due diligence should be thorough and comprehensive as we go into this. I think we also need to take into account not just the skills of service delivery, but the skills of the team of people who lead this work, and we mustn't dilute capability in that area. Now, as you know, Joe, and some others won't, there are some bits of specialised services that are managed at a whole northwest level. There are some bits of specialised services that are managed at a whole England level. Now, I don't imagine that NHS England will be trying to delegate responsibility to us for anything that is currently managed at a whole England level. Now, when we think about whether we want to take on the delegation for things at a whole northwest level, we've also got to be really conscious that our actions do not denude our neighbours of a skill set either. So we not only have to think of our needs, but we have to think of the needs of the wider system. We'll have a team of people involved in taking us through this work, and I think one of the things that we need to think about is how we use the wider board and the input from our partner members on the board to actually influence that process.
Great. Steve?
Just wanted to welcome the fact you've included here a section on the Marmot community altogether fairer issue. Obviously one of the key issues and the objectives of this board is to look at health inequalities and look at strategies and tactics for reducing. So the 22 beacon indicators that you included in the appendix, welcome those, and just to ask that the 9 places are asked to collect data and submit data back here, and we have a yearly board report on what progress we've made using that data, please.
Right.
Just to say I agree entirely. I think much of the engine room and the driver for this will be the integrated care partnership, where they will get into and examine the detail. From those beacon indicators, I think we're showing that there are some things that can only be measured quarterly, some things that can only be measured annually, but absolutely those beacon indicators will come back as part of the performance pack here to this board.
Thank you. Are we comfortable to move on? Thank you. I've just spotted that 2 individuals are standing up. I think we've got some spare chairs around the table. Are you okay? Okay. Okay, thank you. Well, I'm delighted to introduce the next item. The Integrated Care Board and the Integrated Care Partnership is made up of 9 places, and it's really important that we remember that. And it's great that St Helens goes first and is our first visit. I'm sure we'll hear that St Helens is the best, but let's go forward. Great.
Thank you, Chair. So I'll just stand up so people can see, and hopefully you can see the slides, and these are available within the report. So what I wanted to do is just kind of bring some of this to life, and as I mentioned when I introduced myself, I am a joint appointment across the NHS and local government, and we've got some of our councillors here today. So we've got our cabinet member, Councillor Marlene Quinn, and we've got our chair of scrutiny, Councillor Michelle Sweeney, as well as Geoffrey Appleton, who chairs our place-based partnership, who was the CCG chair, but is also now moved over to deputy chair at our local hospital. Alongside, we've got Jane and Sally and partners in the audience today. So it really is a joined-up, integrated approach in St Helens, and something I'm incredibly proud of. So, if we go to the next one, please. Thanks, Kathy. So, just wanted, there's a bit of a process in terms of trying to bring to life what we're doing in St Helens and some of the challenges that we've got. So I'm going to run through these and then come back to the table and take questions from colleagues on the board. So if we go to the next one and the one after. Thank you. So, I just wanted to try and capture the sort of history of St Helens. And when I spoke to somebody and I said, I'm going to go back to 1552 in a presentation, they said, it must be a long presentation you're going to do. But actually, when you think about it, there's a huge amount that has gone on to create the place that we are in today. Not least the fact that there are some of the legacy of that industrial revolution, if you like, that we still see in some of our health inequalities in St Helens today, and some of the challenges that we remain with us. So we can see we started as a something that was quite a small conurbation and have grown into what is the metropolitan borough of St Helens now. And I think the development of coal mining and glass was a huge investment in the place of St Helens. And we've got the legacy of that, both positive and negative. So in our old sort of colliery sites, we're now developing Parkside, which is going to be somewhere where we will have employment opportunities. We've still got glass that's produced within St Helens, and in fact Glass Futures is the second phase of that. We're hoping that we'll get further investment in terms of research and development on a global scale that will come from St Helens and could attract up to another £100 million worth of private investment in the borough, which is really important because when I talk about inequalities later on, 80% of those health inequalities are tackled through the root causes that sit outside of clinical care. It's about employment, it's about housing, it's about jobs, it's about skills. So that's where we are positioning ourselves. But as you can see, a huge history of change, development and investment, but we've got some massive challenges still to come. I think the interesting thing in all of this is that you can see progress all the time. And even when we became a council formally as a Metropolitan Borough Council, we still moved on. We're part of the Liverpool City region, part of that wider network of councils. And I did mention in there, and I apologise to my colleague, Professor Steve Broomhead, who was from Warrington, about the reference, but we do have the most successful rugby team. But I'm sure you'll get me back when we come to Warrington. So, so we could take the next one, please. And after that, thank you. Right, so just wanted to paint a picture in terms of what does St Helens look like. So this is the council budget, or that's the net budget. The gross budget is about 500 million. But that's the net budget, and out of that net budget, the responsibility I have in the council spends 74% of that net budget. So a significant amount. But what you'll see here as well, and what people don't always recognise when they come to St Helens, is we've got a huge amount of green space, open space, across St Helens. So there's all sorts of opportunities that we have in terms of our active lives and things that we can do to promote that, and we're really proud of it. There is more that we can do in terms of our employment, and I think all the work that we're doing, whether it's levelling up bids or whether it's town deal bids, investment into the borough has to be focused on jobs both for our young people but for our people of St Helens, because that's really important that they get those opportunities, that investment comes to local people. So take the next one. Thanks. So this really was just to kind of paint a picture of population size, and down here it's worth just recognising that our registered population is larger than our population that we look at from a council point of view, and it's always worth remembering that when we think about our patient flows. So things that we're really proud of, mentioned our green space, a huge amount of people that work that Sally knows in terms of our volunteers, and we saw a lot of that in terms of COVID and what happened during that period of time. And we've kept those people, we've kept those contacts. Our partnerships are incredibly strong. A lot of the people that are around the table and in the room today are part of that partnership. However, there are some challenges that we have. Some of those are, and we particularly chose the PAUSE programme as the patient story because we do have too many children in care. We need to do something about that. And some of that is about having accommodation that's appropriate within the borough. But also there's something about how do we tackle some of the aspiration. The low attainment sometimes is to do with the education, but it's to do with the aspiration of our young people in St Helens, and we need to continue to raise that bar. And there is something about our COVID rate, so I think Graham touched on it earlier. We were the second highest in the country, and that might be because we're testing more and we're doing more. But that is a challenge for us, and it was a challenge during the pandemic. So if we go on, thanks. This just gives you that kind of life course picture, and again what this paints for you is some of those challenges. Now there's more reds than there are greens and ambers, and if you actually look at the greens, they are more around screening. So the root causes of dealing with some of our inequalities are the challenges that we have, and I'll come on to say a bit more on that in a minute. Thank you. So you won't be able to see this, but this is in development at the moment. We call this our tartan rug because it's a visual depiction of our inequalities across our wards. Because it's really important that not just our primary care networks, but our counsellors and our partners can see what's happening. Now, if you look there, the two big red ones are in Thatto, Heath and Parr. Now, you might say, well, we know that we have some real inequalities in those wards, but when you look across, there's lots of other pockets of that, and we need to understand what that is and why it's happening, and therefore we know why we're targeting some of those interventions. So we go on, Kathy, thanks. So just wanted to share a bit on our integration journey, thank you. So we have been at this for a few years now in St Helens. So we started back in 2018 when I think it's fair to say there was a lot of challenges, both in terms of the NHS system, our partners and local government. But what that did do is it brought people together to focus on the things that were important for the people of St Helens. So we established the contact cares, which we heard about through PAUSE, and also the shared care record, which I think has made a huge difference, particularly working with the Trust. And then we moved into establishing a more formal agreement. We have a memorandum of understanding that gives us delegation, gives us governance around decision-making, around integration. So it isn't just about talking a good game, it's actually about delivering and doing that. We did with others respond during the pandemic, and we had the mass vaccination site at Saints. It was hosted by the Trust and facilitated, and we supported alongside all of that with mutual aid working both ways. That was a brilliant initiative and brought a huge amount of volunteers and partners together. And then moving forward, we are now looking more around our young people. So we are focused, we heard earlier about Marmot, we are focused on those early years for our young people and getting that right now because we will see the benefit of that for them. And also the deliverability of what we've committed to in our partnerships, and I'll pick on those in a second. Thanks, Kathy. So, if we could go to the next, thank you. So this just summarises what we've said in our plan. We've done a refresh of our plan, and our vision remains the same. It is about tackling inequalities. And we've picked these three priority areas, which I'll say a bit more about in a minute. But the reason we picked those three was that we listened to what people said we listened to what people were concerned about, and we looked at where the data told us where some of the challenges were. So those are the areas that we've worked on. And we've got SROs, senior responsible officers, that work for us on that. So Lee, who works for Merseyside, is our SRO, our senior responsible officer in terms of mental well-being. In Healthy Weight, we've got our Director of Public Health. And then in Resilient Communities, we've got our Director of Adult Social Care. So we're making sure we've got senior leadership in there. Thanks, Kathy. So this maps against the council. Because this is an integrated approach in St Helens, it's important to know that this maps against the borough priorities that were set out by the council last year that run right through until 2030. And you could see the first two and you think, well, they're probably the obvious ones in terms of children and young people, best start in life, and promoting good health and independence. However, the others are equally important, because if we don't get that right in terms of stronger communities, green and vibrant places, and strong, inclusive and thriving economy, those things are absolutely key in delivering those challenges to the health inequalities. And what you see down the right-hand side are things that are both consistent for the local authority family as it is for some of our partners and us in the NHS. Thanks, Kathy. So our priorities, as I mentioned, thank you. So the first one was around mental well-being. So within mental well-being, what we said is we want to be able to pick some key areas of, I suppose, development that will happen now. So for example, we've worked with Joe and his team and the Zero Suicide Alliance around and the Chamber of Commerce to say, right, let's make sure that every employer in St Helens is trained on zero suicide. Because we know we have a challenge in St Helens. So if every employer is doing that, they're going to be looking for the signs. They're going to be doing something proactive rather than either missing it or ignoring it. We're also looking at our early years. So we've invested in family hubs. We've got some external funding to help us do that. But again, if we work with our young people early on, when we talk to our education leaders, they tell us that that's the one single thing that is impacting on their young people. So we need to do something about that early on before we're trying to retrofit for people later. So a huge amount that's going on around mental well-being. On to the next one, please. Thanks. So on this is around our healthy weight. Now so food pantries is a feature of what we're doing, and Sally and the team are instrumental in all of that. And they are different to food banks. There's a different criteria for it. But on this, although we need to do that, it's treating the symptom and not the root cause. So we need to understand what the root cause is of why people are having to access those and do something about that. Also around our diabetes, so we recognise that actually it's going to be really difficult for people. Cost of living crisis, fuel, everything that's happening means that diet and exercise and things like that will be a challenge for people. So we're putting in place measures so we can understand where the challenges are and what we're going to do about it. And then we launched an active live strategy across the council to actually do something about getting people moving more. And there's lots that sit behind that, but I'll move on just to the next one. So the resilient communities, this was something about how do we harness what we saw during COVID and all those volunteers and all those people that worked really hard with us to help them help us. And by that I mean making sure that we've got a community that feels that they've got someone standing alongside them that will support them, but at the same time stepping back where we need to and allowing that community to work. So what's key to this? One is around making sure our primary care networks and our localities and the council are working together. The other is about workforce, and I've mentioned there around developing a health and care innovation hub in St Helens. That's about working with the Chamber of Commerce in terms of matching business and skills, and at the same time working with the colleges to make sure our young people that are coming through have some kind of pathway, a career pathway, and that keeps them in St Helens or wider, could be wider, but keeps them in the Cheshire and Mersey family rather than we lose them to other disciplines. Okay, thanks, Kathy. So on the Inequalities Agenda, just a couple of slides on this. We have established an Inequalities Commission. It was really important for us to have this as a subgroup of our People's Board, which is the Health and Wellbeing Board and Community Safety Partnership Board, because we recognise that if we don't have the senior leadership and buy-in of a way to tackle this fundamentally in terms of the root causes, then it probably won't happen, because it'll be everybody's business and nobody's. So we've been really clear in terms of our Marmot commitment, those 1,001 days, and working in terms of our young people. But we've also been fleet of foot, recognising that there is food crisis and fuel crisis, so responding to that at the same time as looking at our Healthy Start as well. Thanks, Kathy. So, just something about engaging with our communities. Thank you. So, these are just some feedback, I guess, of what's happened in St Helens. And the important part about this is listening to our population, understanding what they're saying to us, so hearing what they're saying and then acting on it. And there's a couple of things I'll pull out. The resident survey was really important because we got a really good response to that, and that will help us check back to see if we're focusing on the right things. And the other was the St Helens Cares Festival, where we brought together our professionals across St Helens and to understand how is it that we work together, what is it that we can do differently, and how can we share some of that. Okay, thanks. And this was a piece of work that was done by the Inequalities Commission. And the great thing about this is it talks about, if you look at the tree, you might not be able to see it, but what it talks about is it talks about hanging on to the roots. So there's lots of positive stuff that people are proud of in St Helens, and quite rightly so. And it talks about closeness and warmth. Now, you don't commission closeness and warmth. That comes from a very different place. And it is about the harnessing the community spirit in all of that. But there are other things that are challenges to us that I've mentioned already that we have a responsibility to try and help tackle. But I thought that was a nice representation of what the Inequalities Commission did. Thanks, Kathy. So, this was some of the resident survey, which I'm not going to go into, but basically what it does is it demonstrates within those three areas. So isolation and loneliness we know is a big issue. But the interesting thing in that is that it isn't just about older people. It is around our younger people that are experiencing this as well, and sometimes that gets forgotten. And also in the healthy weight, there is a huge amount to do. So one of the things that we want to focus on is our year sixes transitioning in. So you go out of primary school into high school. Too many of our young people are struggling with their weight going into it. Now that will have an impact in terms of their healthiness, their lifestyle, and moving into adulthood as well. So the survey, really, what it did is reinforce that the priorities that we picked were the right ones. Thanks, Kathy. Okay, and then the next one. This is actually a different slideshow that I had, because I had actually changed. Spot the deliberate error. There's 2 adult social care there. So on this demonstrates that the integrated structure that we have across the council and the NHS is very much around the success of working together. So nobody needs to make an appointment to talk to the Director of Adult Social Care if you work in the NHS. It's accessible, we work together. So within the structure, Director of Public Health, the Director of Adult Social Care and the Director of Children's Services are part of my overall directorate within the council. And then we have our new structure in the NHS. In addition to that, we have a joint appointment across ourselves and the trust that is helping us work in terms of integration. So that is an integrated structure. Thanks, Kathy. And then this is our kind of governance that sits around. Now, I'm not going to go into this, but what this does, it might look busy, but I think it's quite a good representation of what you can do at a local place when you've got lots of moving parts. So we've got a number of different forums that are focused on delivery, but we've also got forums that are focused on engagement, but we've also got the ability to be held accountable. And those 3 things are really important. So working through a local level in St Helens through to the place-based partnership board or cabinet or scrutiny or indeed the ICB board as we're here today, we have the mechanism to do that and the ability to do that and do it in a very transparent way. Thanks, Kathy. So our big ticket items. So final slide. This is about what do we need to do to make a difference to the lives of people in St Helens. Clearly the first one there is we need to deliver on what we've said we were going to do. We've made that commitment and we need to be held accountable for it. We need to improve our children's services. There's a huge challenge in terms of children's services in St Helens at the moment. We need to get ourselves into a better place. We're moving there, but we need to move faster. our care communities, our primary care networks and our localities working across the council and the NHS are key. If we don't embed that, if we don't have that at a local level, then we will just see more demand coming into more acute services. Certainly providing, I suppose it goes without saying, but providing that support to the system around urgent and emergency care, and also tackling the root causes, which I mentioned earlier. There is a huge amount of change going on in adult social care at the moment, which I haven't even touched on, but there is a massive change around fair cost of care, the price to providers and the cap that is being introduced. That I could spend a whole other time talking to you about, but I cannot underestimate the challenges that that brings to the local government family and the impact that has across the NHS family. I think further integration, we need to do more in St Helens. We're not complacent. We're incredibly proud of what we've done, but we're not complacent in terms of more to do. So that integration around workforce, our systems talking to each other and our processes, that's really important that we get better at that and we see further integration. And then the final one that I put there was we are part of the Integrated Care Board. We're part of that system and our other 8 places that we work with. So if we are going to be successful, we need to ensure that we're all improving the life chances of people across Cheshire and Merseyside. Thank you.
Thanks, Mark. Any comments or questions, Mark? Tony?
Thanks very much, Mark. You surprised me. You taught me a lot. I didn't know all of that. So, after having lived in the town for so long, it was still lots of very new things there, which is really positive. One of the slides in the middle I'm familiar with is the tartan rug, where you identified 2 particular areas most significantly different. And then you've spoken very much about the ethos of partnership and the value of integration. Are you able to offer a brighter future for those 2 significantly challenged areas by working in those localities rather than just working at the very high level that we and the ICB are looking at?
All right, Chair, to come back. Yeah, so thanks, Tony. So you're right, and I think the benefit that we've had in terms of our approach to integration so far in St Helens has meant that we've kind of broken down the barriers to what local organisations sometimes see as inhibiting progress for a local population. So what do I mean by that? So tourists, for example, we work really, really closely with tourists as our biggest housing provider. I think it's 1 in 6 properties is either managed or actually owned by tourists. So if we're going to do justice to our population, so if we've got somebody that's in Fatto Heath that's got a respiratory problem and they're presenting at the GPs, but their fundamental issue is they haven't got proper insulation, they've got mould on the walls, that's the root cause of why they're coming and presenting. So as partners, if we're working, as we are, with the likes of tourists and dealing with things such as that, we are going to make a difference for our most deprived communities. And I think it shouldn't be an issue for whatever kind of lanyard or organisation they work for. As long as we're getting the right outcomes for them, that's the important thing. And if they see us joined up and working together, then that will be for the benefit. So I think we are doing that, but there's more to do. But I think we've got a huge platform to work off in terms of the people that we've got in the room today that work alongside us to make that happen. Thank you.
Mark, just a question from me. I was really pleased to see the mention that you were listening and engaging with communities. And lots of our organisations do that. But you often see that engagement happen in an ad hoc way. How are we ensuring that we're listening to our communities, working with them, not just on priorities, but also on solutions in a systematic and forever way?
So it's really important that the voice of the resident gets into the room. So the likes of Jane that sits on our People's Board and contributes in terms of all of the work that we do there. So we've got the voice in the room, and Jane will challenge us on that. Equally with Sally in terms of representation from the sector, that we need to hear to triangulate some of the things that we're doing. Now, there's a difference between listening and hearing what's said, and I think the resident survey was an example of trying to triangulate those areas that we kind of picked off
as being key priorities around the mental wellbeing, healthy weight and resilient communities. But we're constantly going back and checking. So we've got a stakeholder forum that meets, that has representation in addition to all the other groups that we've got. But I think the key in terms of the locality work and the care communities at a primary care level will be that will almost be a daily conversation with your population. So you won't be relying on kind of monthly or quarterly engagements. But we try and work with the sector. So we're writing a strategy around older people. We are engaging the sector to go and talk to the community about that. We're just not writing a strategy and hoping for the best. So but I think it's a constant. You've got to keep doing that.
Okay, thank you. Steve, then Erica.
It's a very pleasurable presentation. I think your comments about the Saints Rugby League in Warrington, we say it's always our year. Just want to ask you about resource, because clearly NHS is relatively well funded and has had interventions around the national insurance precepts, whereas in social care we are suffering from the fact we're massively underfunded and there's issues around demand, and some are describing the social care situation as a national crisis. Boris Johnson made some commitments which were not delivered upon, and I noticed some of the candidates, the two candidates in the race for the Conservative Party leadership, are now also making some commitments. My question really is, at a local place-based level, how are you going to deal with the inequality of resources applied across social care in relation to the NHS?
Yeah, thanks, Steve. I mean, it's a very pertinent question at the moment, and I think one of the things that we're realising on the local government side of things is that you cannot do this on your own. So the huge benefit that we've had of having an integrated service across the NHS locally and local government is that we've not got into sometimes the argy-bargy that you have around continuing healthcare, and therefore you're blocking a bed. Well, actually, we don't have that. Equally, there's more we can do around special education needs and disability, but we have an integrated team as well there. So we're focused on the resident or the child. The reality, though, is that there is a huge challenge that's coming in terms of the fair cost of care for providers of adult social care, and also the cap on care and the number of additional social workers we may need to assess people that would have been traditionally called self-funders. Later on to that, the challenges that we've got in schools and in social care with the number of children coming into care. So the reality is that we, I think, as organisations need to look broader than our own set of boundaries. So I know I'm here representing Place for St Helens, but there is an argument to say that we could look differently in terms of our mid-Mersey approach for certain things. And why wouldn't we? Because actually that's going to help the flow and the people that need to get access to care. So I think it's incumbent on us to look beyond our boundaries as well to see how we can support each other.
Thanks. Erica?
Thank you. Really strong presentation. The themes that I picked out were that real drive of equity against equality. We want both, but that real drive for equity. The voice, I think, really comes through. And then the accountability, you know, the people that you're putting in line. My question really is around the future workforce and giving hope to all the young people within St Helens. If you could just put a bit more sort of flesh on the bones around what you're actually doing in that space.
Yeah, thank you. It is a huge challenge. I think out of all of the sort of things that we look at on a daily basis, the workforce is the one that comes back every single time. And it isn't about the money, because the money could be available, but the people might not. So one of the things that we've talked about locally, and again, this could expand, but we put a bid into the town deal. It was a national bid, and as part of that, some of it was about regeneration of our town centre and other parts of the borough, but the other bit was about how do you have a offer to your local young people that gives them an opportunity to, if they leave school at 16 and do an apprenticeship as I did, what do they go on to? Because there wasn't a career pathway for me. But actually, if we could say to our young people, if you go and do a health and care qualification at the college, what the colleges are saying to us is a lot of our young people will go off and do lots of different other jobs but not stay in the health and care because there is no pathway to support them to become a supervisor or a registered manager, or if they want to become a nurse or a social worker, great. We haven't got that. So one of the things we're trying to do is build that in
but give the opportunities to our young people in St Helens. Now, as I say, that could go broader. It could go broader in terms of our other 8 places across Cheshire and Mersey, but we've got to kind of start somewhere, and we recognise that we're doing a disjustice to our young people in terms of that. So that's one of those. The other will be in terms of how we commission services in the future. So I mentioned that Mid-Mersey. So if we're looking at flows around the hospital, if we were to commission, say, domiciliary care on a Mid-Mersey footprint, actually you get economies of scale, you get consistency in terms of that practice, you get the investment in the workforce, and you start to see, you turn in a bit of a corner then. So I think all those sorts of things will help us challenge some of those kind of workforce issues that we've got. Thanks.
Great.
I just wanted to say something first of all in context. So we're here today. It's our intention to have a meeting in public in every one of our 9 places every single year. Now St Helens volunteered to go first. Better a willing volunteer than a pressed man. So I do, just to acknowledge that, I do also want to say to you, that was an absolutely excellent presentation. You have set this bar so high for your colleagues now. Other things that I just wanted to pick out of this, though, was one of the things that we quite rightly contemplate with the NHS, and that we know that we so frequently get wrong, is we spend a lot of time talking about acute services, and we don't give enough attention to mental health and the parity of esteem. So it was really encouraging to see front and centre of your presentation there the focus on the ambition around mental health and well-being. So thank you for that. The next point I wanted to make was it's a privilege to be part of the system level, looking at the whole 2.7 million population, but come with that privilege is we have to absolutely abhor and want to tackle variation. It cannot be the case that somebody gets better access if they're in Warrington or the Wirral compared with St Helens. So really great that you've set targets for improvement, really great that you've picked out, and in some cases I noticed that the targets for improvement was to say, well, if we're not at the northwest average, we've got to get to the northwest average. But one of the things is we need to be really ambitious, because what if the northwest average, it still isn't good enough for our residents and the people that we serve. So I know that's a bit of a statement. So my question that comes with this is thinking about how we're going to work with and through our places together. And the answer can't be give us more money, because you know we're constrained within the financial settlements that government can give us. Is there anything else you need from us as a board in terms of kind of permission or rules that will help you go further and faster? And if you don't want to answer that today, you can come back and challenge us on that at another time.
That's fine. Yeah. Right. Thanks, Graham. So I think what would help, and we're working through this now, in terms of our target operating models for the ICB and how we work as a place, and we're all part of the ICB, so that's the important piece to reinforce. I think what would be helpful to know is that where we need to seek permission we will, but rather where we need to seek forgiveness, you'll be supportive of that as well, because it may well be that we want to get on and do something and collaborate at place, and sometimes we need to move quickly. So I think it's really important that the board support that approach, if you like. And I think the opportunity to see the collaboration across both the NHS and our wider partnership, I think we've got a lot of rich investment that goes across partners, not just the local government family, but in terms of our wider partnerships. They are really keen to make a difference in their local population. So again, I think the development of the integrated care partnership piece, I think, is really important, because that gets engagement across the board and the wider integrated care system. So I think that ability to seek forgiveness as well as permission, I think, would be helpful. Thank you.
Thank you.
Not yet.
Thank you. Rowan?
Thanks ever so much. I was particularly pleased to see the emphasis on managing the healthy eating and obesity problem with youngsters. It's very easy in the cycles of healthcare, which can at times line up with political cycles as well, that actually tackling that now will make an impact on diabetes, cardiac disease, a whole raft of stuff that has the potential to make the most enormous difference to the health of our population at a generational level. The other thing I'm learning as the medical director now is that our reach through into social care is now utterly crucial. But do you want to say anything about how our reach through into the education world, which I imagine is a crucial supporter of successfully transforming young people's approach to diet and weight and exercise, the education is essential to that. Is that a group that now are coming ever closer to us in managing health, therefore, and are you happy that they are fully engaged with that message?
Yeah, thanks, Rowan. It's a good question because part of it is working with our little ones and getting in there early. So our supporting our kind of early years hubs across the NHS and local authority is key to what we're doing. So there's some of that working with parents and young people now, but then when in the education system themselves, we are working with education leaders both in terms of primary and secondary schools, so making sure that they are, in a way I suppose, making sure that they're keeping a watchful eye on some of the vulnerability of our young people and helping us intervene where we need to, but at the same time not stigmatising, because that can be something that puts young people off or puts parents off engaging. So what we're trying to do is through the active lives strategy that cuts across the whole of St Helens, and in fact the borough strategy that talks about the active lives part is through to 2030, so it goes beyond sort of cycles of political cycles and other things like that. So there's a commitment that council have made on it. But education leaders have stood behind that and said that that's a fundamental part of it. And indeed, Ofsted do measure these things as well now. So so there's lots of kind of triangulation in terms of are we doing the right thing.
Thank you. Thank you, Mark. As others have said, fabulous presentation illustrating some outstanding stuff. Thank you very much. If we're happy to move on, Tony, Chair of report of the Chair of the Remuneration Committee.
Thank you, Chair. Just to provide an overview for this, and Christine will add as she needs to. The purpose of this is for this paper to be noted by the board, but its fundamental role is to provide assurance for a due process in the decision-making of the Remuneration Committee, which consists of the 3 non-exec directors, but supported and challenged by the Chief Executive Chair and Chief People Officer. So to take you to the core of it, Section 3, which is a summary of issues considered and approved. The very extensive discussion had in the meeting about the BSM pay framework. We considered a report outlining the work undertaken and proposals from Graham. What was particularly helpful was the adherence to the 7 points of the criteria there that assisted the committee in coming to relatively simple decisions. Set out in there is the national pay framework, and importantly the first decision was that the committee agreed the salaries of all directors within those ranges, and that we didn't consider any salary in excess of the national recommended pay ranges. We also considered salaries of those placed directors that are joint appointments and who will remain employees of the local authority. The same criteria again was applied. So what we got out of this was a very consistent approach, which produced what we consider to be an equitable result for all those BSMs involved in this. We did discuss at some length the need for a performance management framework, and that's yet to be concluded, but we'll come back to that at later meetings. But one of the important parts introduced was the whole issue of retention of talent, and a statement there that we would seek to avoid compulsory redundancy during the change process. The committee recognises we're in a period of considerable change for all staff, so I think this broadening of the Remuneration Committee's role was welcome. So we do have some further work undertaken, but I just ask that you note the report and take any questions.
Thank you, Tony. questions or comments? People comfortable? Thank you. Good report. Claire, should we go on to the finance report?
Yes, thank you. So my first paper presents the financial plan and budget for 22-23 for both the system and for the ICB itself. You'll note from the paper that the financial plan was submitted on behalf of the system in June, and that was a culmination of a number of months' work across the whole system, and our overall financial position is an aggregation of 17 providers and, as it was then, 9 CCGs across the system. And that planning process was overseen from an assurance perspective and an approvals perspective by the predecessor partner organisation to this, the Healthcare Partnership, and also the System-Wide Finance Committee. So given the timing of us coming into existence on the 1st of July, the need to bring the financial plan to this meeting is for us to note and support that plan, but the approval and the submission happened before we were established. So that's just a point of governance, really. The paper sets out the financial position within the plan of all component parts of the system. You'll see there that there is an overall financial deficit of just over £30 million for the year. Now, nationally, there is a requirement for all systems to deliver a break-even financial position, both within its plan and then also by the end of the financial year. But that 30 million relates to the unavoidable costs of opening up the new hospital in Liverpool in year, and that value is understood and accepted by the national NHS England team. What I've also set out in the paper is the key areas of risks to delivery of that plan, and as you know, we are facing into a very, very difficult financially challenged environment, and the cost improvement plans and targets set out in the paper are challenging in a number of areas, and that's one of our key risks. So section 3.17 does set out those risks in a little more detail, but you know, I am happy to answer any questions on any of this. I won't go through the paper line by line. So that's the first part of the paper, and I'll come back to any points of clarity or questions on that. But as I say, I am asking the board today to support that plan. The second part of the paper is to receive the report that sets out how we will, as an ICB, delegate our ICB budgets to place for this year. And as we've said in the paper, this is very much a pragmatic year one holding position, really, as we continue to do the work on the operating model in terms of how we work together across the whole system. And quite a significant amount of both the plans and the delegations have been already subject to a number of conversations locally and across the system prior to us coming into existence, as the CCGs did their work and their due diligence in advance of the 31st of June, if there is 31 days in June. So I'm not going to say any more on the content. I am going to pause there and open up to wider conversation. You'll note my next paper on the agenda describes the financial position as it stood within the system at month 3. So within that paper, I expect we will be talking a lot more about some of the risks as they are starting to materialise and what we need to do about them. But if we could focus within this part around, you know, those supporting or otherwise of the plan and of those delegations, and then we can maybe pick up a wider conversation about risk in the second paper, if that's okay.
Thanks, Claire. Any questions on this part of the paper around the plan? Tony?
Thank you, Claire. It's just in your initial paragraph, the recommendations actions, asking us to approve the initial splits for budgetary control purposes. Could you just comment on how robust do you think that the budgetary control process are in this complex setup we've got of ICB and place delegation?
Yes, so I think, so, you know, the CCGs had and have, or had, at place level, a number of processes that ensured robust budgetary control. And what we have done and what we considered as a board when we met last is to review all the financial policies and processes across all 9 and to create both the standing financial instructions, standing orders and all the other financial control environments that you would expect us to have in place as an ICB, and we took what we felt to be the best across the 9. We didn't need to reinvent the wheel in many cases and have established those processes from the 1st of July. I think that includes a series of delegations around decision making at local level that hopefully balance the need to provide autonomy and also financial control. But going back to Stephen's points earlier, it is likely that we need to make sure that we aren't hampering local decision making, that we need to make sure those processes can be smooth, decisions can be made quickly, and so I do think it is a period of review and challenging ourselves. Have we got it right? How can we make it better? And I think we're already starting to have conversations with the Associate Directors of Finance for Place to say, what are your examples of where it's not quite working and how can we correct it? And then just to add to that before Steve comes in, we're also, one of the things that NHS England has required of every single organisation in the country really as a condition of some of the additional funding that we've just received for inflation is that there is an internal audit review of a number of the financial controls that you would expect to be in place for a strong financial system. And whilst that is required of all providers, it's very important that we do and hold ourselves absolutely at the highest level of scrutiny for that ourselves as well. So we will be doing a very early review of our financial controls in the next month or so as well, which will obviously then come through to the audit committee.
Thank you very much. Thank you.
Neil?
Yeah, thanks, Claire. A few questions really around the ICB budget. When will we see detail of the ICB budget itself so we understand what we're accountable for here? I'll give you a few questions together. Also in the plan, there's no contingency. All reserves have been allocated, so how much of a risk is that? And the plan, is it based on funded levels of activity or actual levels of activity? And I suppose the other one is in terms of the realistic nature of Liverpool's plan, with a 6.8% CIP and a deficit position which is quite significant.
Yep. Okay. Would you like me to answer those now, Chair?
Yeah, please.
Yep. Okay, so in terms of the detailed budget, so one of the things that when I present the month 3 paper, you'll see it's probably quite high level, quite simplistic in places. It was our first month of reporting, and we are planning to develop, with your input as well, around what the board would like to see, a more comprehensive finance report going forward as we sort of have generated and created our ICB financial processes from the 1st of July. And one of the things that I anticipate that will include is, as you say, the detail around the ICB budgets, but also the cost improvement plan that we've set ourselves as an ICB, detail on our running costs and the challenges that we're setting ourselves to deliver the most, the absolute utmost value for money on our running costs, expenditure, and that scrutiny there. So yes, next month you will see more on that, and happy to take any feedback on any other elements of the reports as well to ensure that we're providing the board with what it needs. The second point on contingency and reserves, you're absolutely right. This is a financial plan in a highly challenging financial environment, and resources, that have been provided into the health service and into Cheshire and Merseyside system from a health perspective over the last couple of years to support the pandemic are now reducing, and we've got to respond to that by making adjustments to our expenditure plans. The early parts of our planning conversations were a much bigger deficit than we are reporting today, and we've really challenged ourselves to make the financial plan as ambitious as we possibly can, in line with national requirements, and also a need to get back to something which is financially sustainable. So yeah, during that period, we played in those contingencies and reserves. So it is, you know, that does increase the level of risk in terms of delivery, and that's why our close monitoring and scrutiny throughout the year, both for our own financial position but that of the wider system, will be really important. And I'll come on to some of those things that we intend to do in the month 3 discussion, if that's okay. On activity, and this is an area that, so activity plans have been developed by individual providers in line with their own demand and capacity planning work, and you know, they've identified what they believe, you know, they can do from an elective recovery perspective, together with estimates on you know, on elective admissions as well, and COVID. And the contracts between the ICB and NHS providers have been blocked effectively for this year, with some adjustments at the margin around something called an aligned incentive arrangement, whereby if there are significant increases in elective activity, for example, that we can move money around the system so that we are supporting organisations to make the capacity investments that they need to make in order to go as far as we possibly can on elective recovery. So, you know, keeping track of our activity is going to be really important to us collectively, because whilst it isn't a commissioner risk as such because of the nature of the contracts, we are now no longer in that environment where the providers and the commissioning financial positions are separate. We are, you know, collectively understanding the financial position and collectively accountable for it. One of the other things within here is an assumption that we will receive 100% of our elective recovery fund, which also is a risk to us. We did very well in the early months, but you know, June was difficult because of COVID. So you know, yes, there are risks, but you know, that's the environment we're in, unfortunately. Yes, and making the decisions that we need to make during the year to deliver, you know, in line with the plan. Your final point on Liverpool. So you know, yes, absolutely, Liverpool University Teaching Hospitals is one of our biggest provider organisations, and also, as you say, has the deficit that we're carrying this year. We are working very closely with them. They are, as you know, as the board probably knows, they're an organisation that is currently, you know, being supported through a SOF 4 management arrangement. So lots of support from the national team around their quality improvement programme and their operational improvement programme, and also their finance improvement programme. So we have an independent financial review that's been undertaken at the moment that we're doing in partnership with the organisation to identify some of the drivers of the deficit, and so that we can work together on a, you know, the Trust will obviously lead that, but working as across the system to understand the financial strategy that the organisation needs to adopt to harness the savings and opportunities of the merger organisation, but also understanding the financial implications and opportunities of the new hospital build as well.
Thanks. Steve?
Thanks very much. A couple of comments, really. I mean, first of all, thanks for explaining the deficit issue, because I'm familiar in the public and the private sector. You don't really start a budgetary year with a deficit. You look to deal with that before you start. But I think I understand the rationale behind that. Also, to welcome the fact that 80% of the allocation is to the 9 places. You've got the 20% back in the centre. Perhaps over a period of time, as this settles down, you might want to move more money to place. But I think that requires, I think, obviously some conversations in here. And certainly it would help with some of the challenges around local government I referred to earlier. Just in terms of the sort of drivers of this budget and the fact that you don't hold a reserve. I mean, inflation running at 10% plus. There's wage demands coming, which are going to be more above 2 to 3%, which most modelling is done for budget setting in the public sector. And yet we don't have a reserve. I've consciously recognised over a number of years that NHS, because of demand pressures, always overspends. Local government isn't allowed to overspend, actually. You know, it's got limited resources to draw upon, the limits to what it can do in terms of council tax rises and in terms of business rates and so on. So I'm just slightly concerned about the tightness of this budget and the fact we don't have the reserves against inflationary pressures and demands on the pressures on the overall systems.
Okay, thank you. So, yeah, note your comments on the delegations. Thank you, and we'll obviously carry on working on those over the course of the next few months for next year. In terms of the availability of reserves, so the financial plan that I've presented today is the overall aggregation of a system plan, which is, as it stands now, the sum total of 18 statutory organisations' financial plans that have been through boards. So there's 17 provider organisations that have developed their own financial plan and put that through their boards, and in some, and I'm not necessarily privy to the exact nature of the contingencies within each organisation, and Joe might want to comment on how they feel, the level of risk they feel in their plans, but I do not believe we have significant reserves even in providers, because as I say, we've had to play those in order to get to a financial position that would be delivered or acceptable nationally. And the challenge for us and the choice for us was, do we increase our CIP in order to give us a reserve or a contingency, or do we play the contingency in and manage the risks during the year? And it's a very, very difficult balancing act. And I think the level of CIP that we've got at the moment, which in aggregate is 4.4%, across providers, is higher than it has ever been, and is going to be in itself incredibly challenging. Now, some of that will be, and it goes back to Neil's point earlier about the figure in some organisations being reported at the moment quite a bit higher than that, so Liverpool reporting a 6.8%. Now, I think there's probably three components to our cost improvement or our efficiency target that I would draw your attention to. The first is there is a regular, routine, annual efficiency requirement that the NHS is required to deliver on, and for us this year that's probably around about 2% of the total. In addition to that, we are required now to look at all the investment that we put in place. So we've had in the NHS a fairly significant amount of resource, non-recurrently, so temporarily, over the last couple of years to deal with the COVID response, and we are now being required to remove some of those measures. So that is also the removal of those COVID measures, and we aren't going to be able to remove all of them. Obviously, we're in a post-pandemic world, and things will probably never go back to being how they were in terms of delivering of healthcare, but we will be able to remove some of them, and that is also included within that CIP target. And then the final thing to say is that organisations in some areas will be able to make technical adjustments that will support the position. They're one-off. They don't, they aren't going to help us on our longer-term financial position. And I think one of the things, I absolutely agree with you, and with, I'm sure all of us would be concerned about the level of risk in the plan and the work that we're going to need to do collectively to deliver it. I don't underestimate that, but we do need to do that work collectively. But I think the exit run rate as we go into next year is where I think I am absolutely focused on as well, because the level of non-recurrent savings planned within our plan at the moment is around about 44% of our cost improvement target is being planned to be delivered non-recurrently. That leaves us with an even bigger problem next year. And given the fact that we are also we have other challenges in terms of convergence to our target allocation, I think next year is one that, as a board, we'll be spending a lot of time thinking about over the coming months, and I'll bring a paper back on how we're going to develop our longer-term financial strategy on that.
Thank you, Graham.
Oh, sorry, inflation. Sorry, Steve. You asked about inflation. So we have all of the financial plans include an assessment of inflation as at June, effectively. So we don't have a crystal ball, and we can't predict world events, so things may change. But we've not developed the plans blindly assuming some nationally mandated inflation figure. We have hopefully built in an element of realism, and we had some additional funding from Treasury to support some of the excess inflation, particularly around energy, and that's in our financial position at the moment. Sorry.
Graham?
Just to emphasise that last point, and it is to emphasise the success of being able to work together with our partners locally, particularly our partners in local government, but also that comes on to education, housing and so on, is made difficult by the fact that we exist in a different funding regime. So Claire has just told you that when the world fuel crisis hit, the NHS was given more money to cover the cost of that by government. Now, one of the problems is when you do things at a governmental level, they distributed the money as a percentage of baseline. And some organisations were tied into their fuel prices for a year, other organisations were just at a point where their fuel prices were renewing immediately. The government are about to give us a further top-up in our funding to meet the costs of the pay settlement that they have agreed with NHS staff. So we do just have to recognise that we just exist in a different environment where some decisions are made nationally. But underlying that, one of the platforms that we should build our success on is effective financial management and effective control of the resources, and not think that we're going to get bailed out. It is a huge budget. You know, £5.7 billion described in here, and when you take the other delegations that are yet to come to us, and with that huge budget comes a huge amount of responsibility for us to do the things to drive out the efficiency, and we have this fundamental duty to the patients and the residents we serve, but we must also remember our duty to the taxpayers as well.
Thanks, Graham. I'm just going to turn to the recommendations. Firstly, Anne.
Claire, one of the assumed resources in the plan is the ERF, Elective Recovery Fund money. And we're all perfectly capable, able, willing, in fact desperate to take advantage of that fund by treating the patients and reducing the waiting list, and we've got lots of people ready and willing to do that. But obviously at this moment it is being absolutely frustrated. You kind of blamed it on COVID, but it's really just general levels of high non-elective activity, which is crowding out the elective activity, because you know the bed occupancy across our patch in the DGHs is just at absolutely unprecedented levels pretty much all the time at the moment. So it's crowding out the opportunity to earn that elective recovery money. So, you know, I guess that'll be sitting somewhere above us, unclaimed and unused, you know. But also it's this thing about we can't get that, we can't earn that money because we can't free up the headroom in the beds to get the patients through. And I was just thinking we could just do with some thought going into, you know, it seems a pity that that will all be lost to us because we can't find a better way to operate than we are now. So I'd welcome a discussion about how we can get into a better place, because, you know, the opportunity to be able, you know, from the patient's point of view, to be able to treat the patients is one not to be lost, but also, you know, it does help us from a financial point of view as well. And, you know, we have to remember we've got, you know, huge numbers of patients in beds who actually could be somewhere else.
Yeah.
Comment, high-level comment.
Yeah, absolutely. And so we are assuming within our monthly position, we're assuming full receipt of ERF at the moment. So it's still a risk because we've obviously not earned it. I'm not, you know, but absolutely I understand your broader comment there about how we work together to maximise our rate of recovery and therefore receipt of that income. So it may be something I'm happy to come to CMAS to work with the elective recovery group as well, and maybe we can, you know, have a re-look at what other opportunities we've got on that, given current non-elective pressures.
And Claire, I took from Anne's comment the need for us to start working on the case that we could put to region and national about the impact of pressures into the system and our inability to hit the elective activity targets. So management upstairs, I heard, is that what you meant as well, Anne? Okay, let's move on to the recommendations. Firstly, to support the financial plan submissions of the 20th of June. People comfortable with that? And secondly, to approve this initial 20-80% split. People comfortable with that? Thank you. Claire, shall we quickly go on to month 3?
Yes, thank you. Okay, so follows on really from the earlier conversation. This paper sets out the financial position as reported in aggregate across the system at the end of June. So slightly unusual month, this one. I'm effectively reporting on the financial position of the statutory organisations as they existed during April, May and June, which were obviously the 9 CCGs and the 17 providers in our system. The CCG's position are now finalised and subject to audit, and the provider position effectively is their Q1 report. The financial plan overall is a deficit for the period, so a planned deficit of 25.4 million, and we've actually delivered a position £1.6 million better than that. So, sorry, I should say the planned deficit was 27 million and the actual deficit delivered was 25.4 million. So that equates to the £1.6 million positive variance against the plan. Now, the first thing to say is that we've just heard that the overall financial plan for the year is £30 million deficit, and we are seeing 25 million of that deficit reported in Q1. So the reason for that, which does point to a very much back-ended risk in our plans, but that as individual organisations have developed their plans, they profile the performance of that over the year. And generally speaking, the cost improvement programme is certainly this year is back-ended, which means there's an assumption that all of the savings that organisations are currently working on will materialise in future months, and that is obviously a real risk for us. And I'll come on to that shortly, and some of the things that we will be doing as a system to get assurance that that work is progressing at pace. So, within the paper, there is some detail, which I'm not going to go through, of individual organisation positions and where those organisations are off track, what is driving that. And as you'll see, at month 3 anyway, generally speaking, the deficit is centred around a small number of organisations. But as the months go on, depending on what assumptions organisations have made about when their CIP programmes will hit, then I anticipate those risks potentially materialising in other organisations, without corrective action, which we obviously need to work on very quickly. So, I'll open it up to questions in a second, and I'm sure there are many. But one of the things we have been developing and will need to further develop quickly is our financial recovery regime as a system in Cheshire and Merseyside. So how do we hold organisations to account for their financial plan delivery? How are we supporting delivery? What decisions can we make collectively across the whole system to speed up and accelerate delivery of cost improvement programmes? Some of the components of that recovery regime, we have already instigated a peer review process which has reviewed each of the organisations in the system with a deficit plan, and that peer review process wasn't led by finance, it was a multidisciplinary process chaired by a clinician. We've also reviewed CIP plans, but to be fair, there's still quite a lot to do on CIP plans, so we've a lot more to do on that, sharing of ideas across the system. I've mentioned earlier about the audit across every organisation around their financial control processes. But we're also talking, and we've got further conversations this afternoon at the executive team, and we've spoken outside the meeting with a number of people around the table already around the additional financial controls that we may need to put in place to really manage the risk in year, and that may include agency. We're looking at our agency spend, and national controls are coming down, but what do we want our own local decision-making or escalation processes to look like in relation to premium pay or agency staffing, for example. So quite clearly a huge amount of work to do and considerable risk in delivering this position in year. I don't have all the answers. This is a collective financial position across the whole system, and individual boards will be having similar conversations like this one up and down the system in terms of, you know, dealing with and delivering their own financial plan and position, and working together, supporting them, but also making sure that we're managing the risks and holding to account as well for delivery.
Thanks, Claire. Any questions or comments? Steve? Neil?
Just my comments on capital expenditure. I mean, we have a £5.6 billion revenue budget. We only have a £224 million capital budget. Yeah. And the bit I don't understand is the role of this board in relation to decisions on capital. I mean, the government have been looking to make investments into 14 new or regenerated hospital sites. And what role do we have in those decisions, and will that be reflected in our budget? Because we seem to be revenue reasonably well off, yeah, subject to things I said earlier. But capital, it's a very small allocation.
Yeah, very small allocation. I mean, we are incredibly capital constrained in the NHS. Very, very. Are you all right for me to answer that?
Please, yeah.
Really low levels of resource on capital nationally. We are allocated a capital envelope for the system, Cheshire and Merseyside, and we are able to determine how that is prioritised. But the £250 million capital budget you see in our plan in the position today, only half of that is the element that we have complete discretion over. The other half relates to national programmes such as digitisation programme or recovery or diagnostics, and those are subject to national bidding processes and business cases. And in answer to your question specifically about the new hospital programme, they are national processes with national prioritisation criteria. As a region, prior to us being here, the region and system partners were asked for input and views of priorities within Cheshire and Merseyside, but ultimately the next round of that will be 8 organisations nationally. So we, you know, the likelihood of one being in Cheshire and Merseyside, is probably fairly low.
Thank you.
Can I just share some comments from the Health Watch Network
Please,
just around the savings that obviously need to be made? Some concerns have been raised about the public's understanding of energy savings and ensuring, what the public's understanding is. When at a time like now, when waiting lists are so long and people are struggling to get treatment and appointments, it's going to be hard going to convince the public that over £68 million worth of saving isn't going to make their care worse. So just a little bit of work to be done there to assure the public, really.
Graham, do you want to give a comment on that?
Okay. So you will remember that the Chancellor of the Exchequer stood up and said the NHS would have whatever money it needed through the pandemic. They effectively wrote us a blank cheque. We didn't operate with a budget, they just reimbursed what we were spending. Now, the government undertook effectively a totting up of that, and whilst they're never going to ask us to give that money back, what they are trying to do is they're trying to reduce our budgets slowly back down towards pre-pandemic levels. It'll never get back to pre-pandemic level because the health budget would inflate every single year. So they are taking away some of the money that we had for dealing with the difficult operating environment of COVID. We think they've taken that money away a bit too soon, but that's their right to make that decision how they make it. You've then heard Claire and others talk about the Elective Recovery Fund. If we can do the work, there is no limit at the moment on how much extra money they would pay us for getting more patients and more procedures through, but we are restrained from the capacity we've got, and we are restrained by our workforce. So if it's about clearing the backlogs of the waiting list, if we've got the spaces on the wards and the operating theatres, if we've got the surgeons and all the support staff to do the work, the money will be there, but it's a really, really difficult operational challenge for all of our hospitals.
I think it's also useful to add that each one of our organisations, the provider organisations, will do a quality and safety impact assessment of all their productivity or cost improvement programmes, which their medical director and nurse directors are responsible for, and we'll see the parallels with our medical director and nurse director to assure us that any productivity and cost improvements aren't causing any safety issues. Okay, we're happy to move on. Neil, sorry.
Couple of questions. I recognise this year is a year of getting through, so I'm more concerned about the strategic position of the ICB and the strategy. I know Claire's working on, but to understand that, because at the moment what we're doing is putting money where it's needed. We're addressing waiting lists where people are on the... It's not about equalities or population health, it's about just the clear immediacy. So it's the financial strategy that actually moves us forward, going forward, where we will see that, and whether we will see pace of change distance target for places, because it's very important for places, because I see North Cheshire's got a £69.9 million deficit, but is that based on fair shares, or just what they're getting? So it's the longer term strategy of the ICB to support inequalities population and give fair shares to people once we've got through this period. And my second question was quite a simple question. On the Better Payment Fund, all the hospitals are cash rich, but we're not paying suppliers. And in these days, the economic challenges, that seems a poor record for us.
Perhaps we could say to your first question, Neil, and great, on the comment. The answer is yes, that's what we want to do, and we will be developing a financial strategy.
I think both colleagues know that Claire Watson will be leading a process to set out a 5-year plan for the system. That 5-year plan will be signed off by this board no later than March next year. Actually, the process of engagement to do that will be as important as the plan itself, and that plan will be underpinned by a quality strategy, a digital strategy, a workforce strategy, and a financial strategy.
Thanks, Graham. Claire, better payment?
Yeah, completely agree. I think big area of focus nationally as well, and I know that the regional finance director has written out to organisations that aren't delivering on the target. So I'm continuing to work with and push that message with finance directors, colleagues, and find out what the blockages are. And I'll mention that the board are keen to track that as well and make sure that it's reported every month here.
Okay, thank you.
Good questions, thank you. Are we happy to move on? Thank you. Tony?
Thanks, Chair. So thanks for allowing me to report this performance report. I think the first comment I'd like to make, as I set out in the cover sheet, is about the recognition that this is a developing reporting process. We fully intend to integrate quality, workforce, finance and performance into one overall pack, and we'll use the Quality and Performance Committee, which Tony referenced earlier, which meets next week, to provide the oversight of that as we develop over the forthcoming months. But I think, when we heard those earlier comments before from Graham about the operational pressures, we were very keen to bring to board a number of indicators that highlights that situation. So we've chosen a number of central indicators. These are the ones primarily that are set out within this year's current operational planning guidance. But we absolutely recognise it's not covering all sectors. For instance, it's not covering mental health, and that is something that we are told will be much more reflected in the forthcoming planning guidance, which we believe will be released in September this year, as opposed to what is normally a Christmas event. And it will look for plans over a longer period than just the forthcoming 1-year period. So next month, if it's okay, Chair, I was suggesting that we bring back some of the detail as a reminder of the targets that were set, or the objectives and standards that we're aiming to achieve in this year's operational planning guidance. If the timing works well, we may be able to provide some insights into the forthcoming planning round as well. So if I can, I won't go through page by page. I'm sure everyone's had the opportunity to digest a lot of the data we've got, but I'll cover 4 main areas if that's okay. The first one being urgent care, and I think Anne's just articulated the current state of pressure that we're seeing across all sectors, whether that be primary care, whether it be acute hospitals, whether it be the social care environment, mental health or community services. And to articulate that, if we look at A&E attendances, which is often used as a barometer of that, we know that we're about 7% up compared with pre-COVID periods. Similarly, when we look at primary care, they similarly are 7% up in terms of GP appointments that are being provided at the moment. That is a mixture of both face-to-face and telephones and other purposes, but again, that patient demand is there. We're seeing very high occupancy, as Anne said. You know, we can talk about the differences between 98 and 99 and 100% occupancy within an acute hospital. The reality is that's full, because there's always people sat within an A&E or on the way in via ambulances or walking in, so that is full. And whilst there's a number of components to that, one of the elements, as was touched on earlier, really is, you know, we are seeing successive waves of COVID. So whilst it may not be publicised as much as we've seen in the past, if we look at the position across Cheshire and Mersey through June and into July, the latest wave or the latest variant of COVID brought about a position where 9% of the bed stock in the acute hospitals was being managed for COVID patients. Now that's not far short of the 11% that we experienced in January and February in the first Omicron wave. So a really, really challenging situation. And whilst hospitals are adapting to how they manage those patients, it still creates an awful high level of occupancy for them. The workforce challenges are uniformly across the board, and some of the work that we've seen, particularly in the social care sector, we're beginning to believe may have some early signs of help. So I cite an example in Cheshire that has been done recently, recognising that the social care market was challenged, workforce choosing other industries, also coupled with the fact that it's a remote area and rising fuel costs. So the CCG, as was the acute sector and the local authority, have worked quite proactively in that area in recent times, have recognised that remuneration is a significant factor and have agreed to uplift those remunerations. They've done that by actively working, looking at the BCF, the Better Care Fund that works across that system, and critically appraising and in some cases stopping individual initiatives that don't necessarily seem to be bearing the fruits that they would have. So it's a way of us trying to control within the financial envelope a change in the provision. And I think it's probably an early indication of how the ICB can start to play out in a more wider arena. I won't go through some of the detail on the metrics. People can read them for themselves. We can see what the consequences are having in terms of long stays in A&E, struggling to provide ambulance handovers, struggling with ambulance response times. But I think what we would say, certainly within the ambulance response times, is you can see a clear effort being made by the system and NWAS to try and respond to Cat 1 and Cat 2s, even if that means that Cat 4 patients, that the response time is much longer. If we move into elective or planned care, again, as everyone's aware, we've got a significant focus on trying to recover activity levels to where it was pre-pandemic, and we're having some success in that, but absolutely challenged in some areas, as Hannah's just talked about, in terms of the non-elective admissions, pushing those elective and day cases out on occasions. But we are seeing some progressive work in outpatients where it's less affected by urgent care. We're over 103% of outpatient activity compared with pre-COVID. And what's encouraging is that we're seeing a change in the way in which outpatients is provided, with an ever-increasing number of follow-ups being patient-initiated, not the cycle of return every 6 months to an outpatient visit. So again, that is providing more of the capacity that we can use for new patients and tackle some of the waiting times. If we look at the latest objective around how backlogs are being measured, there was a key national indicator as part of that phased reduction back down to the 52-week and 18-week constitutional standards of achieving eliminating 2-year waits by the end of July. And I'm pleased to say that whilst it was right up to the wire, Cheshire and Mersey was able to report 0 over 2-year waits at the end of July, and we will work on that continually towards the objective of eliminating over 78-week waits rates by the end of March. Cancer. Cancer was a position that even through COVID pandemics, activity levels were maintained in cancer. But what we also saw at that time was a significant reduction in cancer referrals. And since the pandemic has moved to the current phase, we've seen a real surgence in referrals through primary care and into hospitals. And it's good to see that the hospitals are performing 109% of the treatments that it did pre-pandemic. But we've got some significant backlogs to address, and it's coming down slowly. So our backlog for cancer treatment is twice the size it was pre-pandemic. However, the comforting and the mitigation around that is that these patients are tracked on a weekly basis through a multidisciplinary clinical team, and their treatments will be brought forward and adjusted dependent upon the clinical condition of the patients and the overall backlog that exists. And the Cancer Network has worked very well during the pandemic periods to ensure access to treatment by almost sharing waiting lists and allowing patients to move around between various sites to get their treatment, something that we need to move on in terms of our approach to our overall management of planned care pathways. And we're working with our elective programme leads, which comes underneath the collaborative arrangements that Anne chairs, and increasingly taking them to a dimension where we're looking at that rather than tracking the individual delivery at site level. It's about the creation of more mutual aid and combined waiting lists. So I'll stop there if that's okay, Chair. Quite happy to drop into any of the questions or detail, but hopefully that gives an overview of some of the pressures that we're currently experiencing, but more importantly what we're attempting to do around it.
Thank you. Questions or comments? Report in progress, work in progress.
Thank you, Tony, for the report. I think actually it's quite easy to pull out some of the pressures. The bit I'm a little bit disappointed with, and possibly it's an area for development, is primary care's wider than just general practice. You've got 3 general practice measures in there, nothing for dentistry, nothing for optometry, nothing for pharmacy. And given we've already taken responsibility for pharmacy and we're going to for the other 2, I think actually there's some work you could do perhaps with Primary Care Leadership Forum to figure out what metrics and how we can get that reporting in, and I'd offer my help on that if you...
And that'd be very welcome. I mean, we do have the business intelligence leads from across a number of sectors, be it local authorities, social care providers, etc., working on the establishment of a balanced scorecard for a great deal of metrics rather than one page that you see here. But absolutely, I'll take you up on that offer, and we'll integrate that into the overall pack.
Good point. Joe?
I think Anthony knows what I'm going to say. So no reference to mental health, learning disability or community services. I mean, I get we are where we are, I know that, but I seem to have been having that conversation for a very long time. We sit in an ICS area with the highest prevalence and incidence of mental health anywhere in the country, underpinned largely by, lots of the social circumstances and so on. Question is, what does it say about us that we're taking so long to put our metrics in place around this? I mean, are we institutionally here stigmatising people with mental illness? We're not shining the same sort of light on them. Now, I don't think for a minute that's our intention, but I think we do need to move probably more rapidly to the sentinel group of measures at least. I mean, Mark came up with a brilliant one, which is looked after children. That's a fantastic indicator, all in its own right, really important, but it tells us a lot about how systems are operating if we pick a few of those sorts of indicators. So I don't see why we can't do that and do that very rapidly, because we have the data. If other places don't have the data, at least putting it in place forces them to address their data quality issues and so on. I'm not being critical. I know how difficult it all is at the minute, but it wouldn't be right, I think, for me not just to say that.
Very important challenge.
I absolutely recognise it, and yes, it is part of the development of the overall paper. But I absolutely share your frustrations. We've had a number of conversations when we look at, even in the current operational planning round, there was only one indicator for mental health, alongside 40 or 50 for the acute sector. So we have been given assurances that nationally that will be recognised through the latest planning guidance, but let's not wait for that. We can bring our own metrics into it, can't we, which we need to focus on.
Can I ask, Anthony, for next time, we do see some reflection of mental health and the wider primary care service. And we know how difficult it is. So best endeavours, please.
Absolutely.
Thanks. Okay, are we comfortable to move on? Thank you. Fiona?
Thank you, Chair. So the paper that you've got in front of you this morning on the establishment of the North Mersey Comprehensive Stroke Centre is here for a decision building on the conversation we had at our shadow board. I have colleagues with me, I hope. Hi. So I have Dr. Claire Cullen, who is clinical... are you there, Claire? Come sit. One of our leading stroke consultants across the patch, who's here to answer any clinical questions, and I have Carol Hill, who's the Director of Strategy for Liverpool Place, and who has been SRO on the stroke programme. So what the paper outlines for you today is the strategic context and the proposed clinical model which the board were introduced to in June. I'm going to take that as read, but I want to draw your attention to a few elements of it. So specifically governance, outcomes and finance, and I'll bring colleagues in to talk about that in due course. Section 8 gives you the details of the extensive process that this has gone through over quite a protracted length of time. This work started 2015. Hi, Helen. 2015. It was protracted in part due to COVID. It definitely got held up by our attention being elsewhere during the pandemic. But we are now at the point where we're asking for a decision, and we have a final OSC meeting scheduled for September. Over the last 5 months or so, the process to bring this to the board has been accelerated due primarily to the concerns about the sustainability of the stroke service at Southport and Ormskirk Hospital. We reached agreement at Chief Executive level that the service needed to move more precipitously, and we've agreed that that needed to happen in September to address those clinical risks at Southport and Ormskirk. That approach, or that challenge, has been met by a very collaborative approach between finance colleagues, clinical colleagues, and the wider stakeholders involved in this. The other point on governance is that on the 27th of July, Lancashire and South Cumbria's new ICB took this paper for a decision and supported it, with some caveats. I'll talk in a moment about some of the challenges that we've had, but they want to be very involved in the next phases of the work that we need to do to make sure that this not only mobilises safely but continues to develop in the way that we've planned. So we really welcome their support and keenness to be involved. Section 7 talks about outcomes. So in June, the board specifically asked the question about how we will know whether we're making a difference and whether our outcomes are improving. So what we have done is developed a local dashboard. So we have our national SNAP data, which colleagues can comment on in a minute, but we felt that we needed to go further than that. So the dashboard that is in the paper in front of you today, it's basically a snapshot of where we're up to with it. There is more work to be done on it, but actually credit to our BI colleagues who've pulled that together very quickly for us, and I think it's looking very promising. I would just draw attention as well to the finance section. The original pre-consultation business case was done 5 years ago. With the benefit of hindsight, it's clear that there were gaps in some of the assumptions that were made. Some of the assumptions were made in, I'm going to call them ordinary times, pre-COVID times, and as we've been hearing in our performance report, we are existing in a very different world, and the system's under considerably more pressure now. There is a lot of learning for us when we do further reconfigurations and pre-consultation business cases to do perhaps some more horizon scanning, and the system has committed to do that learning together, and specifically using stroke as an example of how we can learn. The costs, the significant increase in the costs come from a range of sources. So diagnostics, there's much more that we are expected to do now. The complexity of pharmacy input is greater, but the vast majority of the staff cost increases come from staffing. That is primarily to do with the fact that the assumptions that we made about staff being, if we built a hyperacute stroke unit at the front door of Aintree Hospital, it would relieve some of the pressure on the A&E department, and some of those staff resources could be used, but that is clearly, as I say, a different scenario now. I would just, should we start with the finances, Claire? I was going to ask you to just comment on the finance section and the numbers.
Yes, of course. Yeah, so just very briefly, you'll see in the paper, but also in the business case, which has been circulated, that the total annual cost is estimated at the moment to be just over £7 million, compared to a pre-consultation value of around about 2.8 million, for the reasons that Fiona's described. I think what we've had a number of sort of review meetings with the finance and wider clinical and operational community on this, because clearly that is a significant investment, and we need to be absolutely clear that it's the right model, and the value is there. So we've identified £2 million within the ICB budget this year to support the in-year costs, which I think are around about 2.3 million. So we're supportive of that, and that's there. But we, I think, need to do more work, and we've agreed with all partners, the providers, to do more work over coming weeks and months to really nail down the annual costs, and ensure that this is a value for money model for the benchmarking and etc. But we're very conscious that this clinically has to happen in September to support the clinical risks that are set out in the paper. So from a pragmatic perspective, we are supporting this as it stands at the moment, with that further work to do on the affordability long term.
Thanks, Claire. And I was just going to let the other Claire comment. Oh, yeah, Chair.
I was a bit confused when we were, being asked to approve the thing, whether we were approving the principle of a hyperacute stroke centre, which 100 million% I do, and against, do we approve the business case with the numbers it's got in it. So I welcome Claire's comments about maybe we need to have some scrutiny of that, because if you looked at the additional number of stroke patients that are going to come into the centre, as i.e. who over and above the existing Luft, the Royal and Aintree patients, it's only really the Southport patients that are extra. And if you did it, in the days when we did the Mid-Mersey hyperacute stroke unit, it was PBR, and to take that number of patients would have yielded about £1 million in PBR. So it's an awful long way away from the 7 million, because actually the numbers are smaller than when we took on the Warrington patients into Mid-Mersey. So it is, and the other thing, wow, because I've got the microphone on, is there will be some drift into Whiston from the Royal, and that's not even mentioned anywhere in it. And of course that is a capacity issue. So I'm not even arguing about the money, but the principle that you will get that population that is shared between Whiston and the Royal, which is significant. Actually, the chances are that those some of those strokes will end up in Whiston. It's against this thing about, we need to just consider always about what goes outside Liverpool as well. Thanks.
Thanks, Anne. We do need clarification on what we're approving here, and Claire thought helpfully said we're not approving the business case. Yeah.
We're approving the mobilisation of phase 1, so that they can get on and do that in September, but we'll further work on the financial model. Okay.
Yeah.
Fiona?
And we are also doing further modelling as well as financial on flows, taking that point into account, and that was feedback from our South Cumbria and Lancs colleagues as well. I was going to ask Claire to comment on the outcomes and measures.
Yeah, I think it's not straightforward to say that we're just taking an additional 400 patients. We're creating a gold staff-led service, which is going to deliver for the people of North Mersey. So that requires investment
is a national optimal stroke imaging pathway that's come in place, and we need to sort of try and realise those standards. I really welcome the fact that we're going to continually review the outcomes from this, and it's really important that we do that. I would say that, you know, initially when we start in September, I would expect us to see an improvement in SNAP performance, but we will not realise all the benefits of this collaboration immediately, because we will still need to do some recruitment. We will have the new build stroke ED ready from April. The new HASU that will be built will be another sort of year or so down the line as well. So we just need to realise that. In terms of realising all of the benefits of this, one of the key drivers to all of this has been around thrombectomy. And if you're interested in reading more about thrombectomy, the Stroke Association Saving Brains report was published last week, where you'll see that the rates of thrombectomy are well below the 10% that we should be aiming for. Across the Northwest, it's 1.8% of patients receive thrombectomy. Looking at our figures within Luft, it's probably around 2.5% the last financial year. Within a 3-year period, we've gone from 6 patients having thrombectomy a year to 41. So regionally, we're improving rapidly, and in comparison to other trusts, we're ahead of the game. And having all our patients come to one site with access to the latest imaging and across a bridge from the Walton Centre is going to be a game changer in terms of how we're able to treat patients. So I want to say we're so excited for September and sort of realising what we've worked on for years coming to fruition.
Thanks, Claire. So we are asking the board to approve the proposal, including the business case, with the caveat that we are going to do some more work on that collectively as a system, which was the position that Lancashire and South Cumbria took. Thank you, Chair.
Raj, can I just... Please, yeah. A question, just a principle here, because, I mean, clinically, the case is great, but to move from a £2 million outline business case to a £7 million case, and then what is going to be the cost, it's a bit of a concern in terms of the planning behind it. 25% so I think we need to work through some principles about developing business cases with people, because I think sometimes they don't have that future horizon and what's coming. They look at it today and then underestimates the potential. So if we're going to take proper capital investment decisions in the future, I think, Claire, maybe you need to work with the teams on how to actually pull together outline business cases so that we actually capture this advancement, because nobody can deny the advancement, but I think maybe organisations just look at what's there today. A bit like the Royal, I could never understand why there's a £27 million cost of opening the Royal. That should have been accommodated in the bid. So it's nothing to do with the cost of opening of the Royal. It's the poor business casing process, I would suggest, and I think we need to look at that to help them, and it's not a criticism.
No, I would agree with you completely, which is why we've committed to doing the lessons learned exercise from this one. I think COVID has had an impact because we lost 2 years in the middle, but you mentioned the point about it not being planned and managed, and we didn't do it for 2 years, and then the clinical risks escalated, which meant that latterly we've been chasing our tails to play catch up, but I agree with you completely and would welcome that.
Thanks, Tim. Anne?
I'm really heartened to hear about the gold standard service that you've conceived and designed in. But obviously we need a gold standard service for the whole of Cheshire and Merseyside and not just for North Mersey. So we do need to bear in mind here that we are responsible for the whole of the patch, and what we can't have is a gold standard in one place and a bronze standard in another place, just because of the timing or the opportunity or whatever it is. And, you know, I recognise entirely this issue about thrombectomy, and we're absolutely not where we need to be. But what we've seen in many of our specialist services is the closer your proximity to Liverpool, the more chance you have of getting access to that kind of service. And what we need to absolutely ensure again is that everybody in Cheshire and Merseyside has got the same access to the likes of thrombectomy and a gold standard stroke service as the residents of North Mersey have.
Yeah. Could I respond to that?
Please, yeah.
I met with the stroke, so we have a Cheshire and Merseyside stroke network, as you know, and I met with them last week and we were discussing this paper, and I said to them, if this board have read the paper properly, they will ask me the question about what about the rest of Cheshire and Merseyside, and so the work plan of the stroke network absolutely includes addressing that.
Thanks, Fiona. Any other questions or comments? The clinical case, the patient case, absolutely great, and the aspiration to go for gold standard is a must. Why would we want to aim for anything else? I am not yet clear about what we're trying to approve here in the absence of an approved financial plan. So just, are we making a decision to approve a case that then has an an unstoppable implication on a financial plan, on our finances? Could somebody just give me a view on that?
So if I could ask Claire a question, if the board approves the full business case as it is written, does that preclude the system from reviewing that full business case and pulling costs out of it at some future point?
It doesn't preclude that, but it's whether the board are comfortable with that, given the differential.
The risk that, yeah.
It's maybe the other way around, perhaps.
It's normally really difficult to stop something that you put in chain. And we don't want to stop it if we can find a solution. But that additional expenditure comes at a significant opportunity cost, as we've heard in this meeting earlier on from our financial plan. Graham?
There are a number of moving parts here. And Fiona's referred to kind of COVID and the passage of time and the impact that that's had on this. The other thing, and Anne started to refer to it, we're also in the middle of a change of financial regime. So pre-COVID, hospitals got paid on a payment by results by the volume of work that they did. As we come out of the COVID funding regime, this was different. We're moving into a system where systems have to constrain their overall costs within a capped budget in a collaborative way. So we are also in the business of whether the cost is real, but also we're in the business of who pays. Yeah? And the expectation that we also bring to bear that there is a level of financial support in the system for the acute sector in Liverpool. They will have to absorb some of the costs within that financial support that is already in play, and the legitimacy of that wider peer review by our provider collaboratives to say, are these costs reasonable? Because every cost you incur in one place is a missed opportunity to incur it somewhere else. So I think we should approve this for clinical implementation, but people should be under no illusion that we will be driving very hard how much of this has to be constrained within the cost envelope that is already being paid to Liverpool University Hospitals, and the notion of peer review to make sure that we've got this right and fair. Okay, so that's a way forward. Are people comfortable then to approve this case? Yes, okay. Thanks, Fiona. Thanks, team. The finances aside, fantastic work. Thank you very much. Let's turn to the agenda. The next agenda item is on virtual wards. It's here for information. I don't know if somebody's here to present it, other than yourself.
I can give it a quick praise.
Well, I was going to suggest we just note it here. Okay. If anybody's got critical questions on it or a comment they want to make, let's hear them now. No. I would say, why can't we go further, faster into that coverage? It seems that we could, perhaps.
I think we need to pay particular attention to the current occupancy of virtual walls to understand the lessons learned before we start expanding at a great pace. So we've got capacity at the moment. In some cases it's underutilised. Okay. So let's take lessons learned from that before moving to the next page. Okay. Is my proposal. Yeah. All right,
understood. So good development, but as we've just heard, there are things that we need to learn before we roll it out more. Thank you. I'm going to go to questions that have been raised by members of the public of the board. I'll read a couple of questions. We've had quite a number, and given the time, I'll just do 2 or 3 of them. I'll read them out and then ask the appropriate executive officer to comment. The first question I'm going to talk about is patient choice and the NHS backlog. Would the board consider taking positive and urgent action to inform people on the NHS waiting list that they have a choice of where they are treated, and that by travelling what may be short distances, their waiting times could be reduced? Anthony?
Yes, I think that's absolutely the next stage of our transformational approach for the elective programme. We know patient choice is offered at the point of GP referral, but once on those waiting lists, we recognise there's in some cases inequity of access. So part of the elective programme is that we're going to look at how we can gather that information and share that with patients to inform any sense of direction.
Thanks, Anthony. Second question, again it's for Anthony. The performance report doesn't have 52 and 18-week figures. Are they available?
Yeah, they most certainly are available. As I mentioned in the earlier part of the performance report, they are NHS constitutional standards. The key sentinel measures whilst we're in this period of recovery and reduction of backlog has been on 78 weeks, but absolutely happy to put those 2 metrics in as standard as well.
And will they be available publicly?
Yes, they can be. It's published information, so we can gather that.
Thank you. Next question for Graham. Does the service specification, this is about Liverpool Independent Clinical Services Review, does the service specification require Carnal Fire to reach a conclusion compatible with the introduction, or are they free to reject the assertions and the perspectives of the Liverpool One strategy?
Okay. By its nature, this is a limited review, and that limited review has to start from somewhere. So the review is about taking what has been done to date and helping that accelerate and move forward and develop. So we are not asking people to come in with a blank sheet of paper and start again. But of course, we've appointed these reviewers through a very rigorous test and competition, and if they think that there is something fundamentally flawed in the way that we are working now, we would expect them to bring that to our attention and discuss and agree with us how we shape that in the future.
Thank you, Graham. This one's for Chris. It's driven by the Ockenden report. What will Cheshire and Merseyside's Ockenden funding be spent on? Yes.
Thank you, Chair. So the local maternity and neonatal system will provide assurance to the ICB in relation to the totality of the Ockenden agenda. So the LMS have identified and agreed with providers the formula for the allocation of funds for respective providers. I think other aspects of the question refer to the LMNS will monitor and provide assurance to the ICB that the funds are used to recruit and achieve the objectives and meeting the immediate essential actions detailed within the Ockenden report and also of the Birth Rate Plus. And within the ICB, we've got the Scheduled Quality and Performance Committee and the System Quality Group within the ICB that have timetabled the agenda items to receive assurance in respect of all things related to Ockenden.
Thanks, Chris. That answers the other 3 sub-parts of that question. I'll stop going through the public questions at that stage. But as I said at the beginning of the meeting, we will ensure that those people who've asked those questions will get a full answer back from the appropriate officer. Going back to the agenda, any other business? I've not been notified of anything. No. Okay. Just some concluding remarks from myself. It was the first meeting really of a increasingly proper agenda. By proper, I mean a wholesome agenda that covers the work that we're setting out to achieve with all our partners. We know it's work in progress and there's more to be done, and we know there are certain areas of our remit that we will see more from in due course. We do periodically a review of the effectiveness of this board, and in due course we will do it. One of the key messages I wanted to put across was I thought the presenters for the board presented really, really well. Thank you, Mark, for taking the time. That was a really good place-based presentation. And I was really encouraged to hear the comments and the questions from all directors to ensure we got into a good place. There are a number of really important items that we discussed today that we will work with the comms team to ensure that they go on onto our public website in an appropriate manner, so that we can reinforce the live streaming of this board with the public. And I'll end by saying to members of the public, thank you again for attending here today. It's really, really important that we do see you bring the stuff that we have on paper to real life, and it's a really, really important thing that you do. Thank you. Thanks, everybody.